Hello, everyone, and welcome to Our Lady of the Lake Regional Medical Center in Baton Rouge, Louisiana. I'm Margaret Lawhon, your moderator for this evening's webinar and discussion on bariatric surgery, also referred to as weight loss surgery. We know that for a number of people, the question of weight loss isn't just a matter of discipline or finding the right diet or even a quick fix for obesity. Rather, it involves making the right choices and changes to your lifestyle with a physician's guidance, and oftentimes that leads to discussions about bariatric surgery. With that in mind, we have invited a panel of experts to be with us this evening to join in this discussion and to give us some insight into what this is all about. First of all, we have with us Dr. Carl LeBlanc. He is a bariatric surgeon with Our Lady of the Lake with a lot of experience. And Dr. LeBlanc, thank you so much for being with us. We appreciate your time and your expertise tonight. Sure. Also, Dr. Kenneth Kleinpeter, who is also a bariatric surgeon and a member of the team here at Our Lady of the Lake. Thank you, Dr. Kleinpeter, for being with us.
Thanks for having me.
We have a special guest, a former patient who is here to tell a wonderful story, Rachel Wheatley. And when you see Rachel smiling as she is now, you will soon find out why. She has a success story to share with you all, some details that can really give you a look at what the procedure is like from the start to the finish and moving onward with a successful weight loss. So she is going to share that story with us. Just to give you an idea of what we're going to be doing throughout this webinar, first we're going to talk about the different options in bariatric surgery, benefits, risks, what to expect in surgery, and also the importance of support. We want to first invite you to participate with us. You can do that very easily by emailing us your questions. There's an address at the bottom of your screen, socialmedia@ololrmc.com. We'd love to have your questions either for Dr. LeBlanc, Dr. Kleinpeter, or for Rachel if you have a question for her as well, anytime throughout this webcast. First of all, let's start, doctors, with just a brief definition, if you will, of the different types of bariatric surgeries available. There's not just one, there are actually three. So, Dr. LeBlanc, would you give us a thumbnail sketch, if you would, of gastric bypass surgery?
Well, the gastric bypass surgery is simply making the stomach really, really small. It's about 2/3 of an ounce when we're done. And then we actually use some of the small intestine as a bypass segment to bypass the stomach and the first part of the small intestine.
Okay, and this one's been around for a while, correct?
Since the 60s.
Okay, wow, that has been around for a while.
Yeah.
The adjustable gastric band, the lap band, I've heard it referred to, Dr. Kleinpeter. Explain that to us, if you would.
The three operations, the common theme is to reduce the size of the stomach, and so the laparoscopic band definitely does that. The adjustable term is important because when they were initially thought of, it was a fixed band, and so if you weren't in a good position, it was difficult to make that better. So the adjustable bands now allow you to have some flexibility in terms of tightening and restriction to make it a little bit more difficult to swallow a large volume of food at any one point in time. And so the size of the pouch of the stomach is similar to the bypass, what was described by Dr. LeBlanc, and can be adjusted.
Okay. All right. That adjustable term definitely is there for a reason. Sleeve gastrectomy. Some of these terms are kind of a mouthful. Dr. LeBlanc, describe that. That's the newest one, right?
That's the newest one. It's really popular. And basically, there's a calibration tube that we put down through the mouth into the stomach, and we use that as a guide to remove the majority of the stomach, and that is really the only procedure where something's actually removed.
Wow. Rachel, I'm sure this sounds very familiar to you. You went through quite a process of education before you came to your decision. Does this sound familiar?
It does, yep.
For patients, it seems to me that one of the first questions would have to be, when you look at these choices, what's the right one for me? Is that sort of where you started with all this, Rachel?
Yeah, I had to consider which option would be best for me as well, and the sleeve was the best option in my viewpoint.
Well, we're going to get into more of those details in just a minute, but first, just to take a look at, generally speaking, who might be a candidate for this type of surgery. In looking over the information that's available about bariatric surgery and doing a little homework, if you will, for this webinar, I kept coming across the terminology morbid obesity, that term. Dr. Kleinpeter, when we talk about that, we're not talking about somebody who might want to lose 20 pounds, maybe stopped going to the gym for a few months, that kind of thing. It's more significant than that, right?
Absolutely. Morbid obesity refers to a threshold at which height and weight calculated together exceeds a certain point, at which point the risks of letting that obesity go on over the course of a lifetime would potentially shorten the lifespan. So when we talk about morbid obesity, we talk about BMI, or body mass index, greater than 35, and other significant comorbidities, heart disease, hypertension, high blood pressure, high cholesterol. that person would be a candidate. Just having a BMI of greater than 40 is criterion in and of itself. For someone who needs to lose 20 or 30 pounds and can probably do that with diet, exercise, the risk of the surgery is probably not worth that potential benefit to that person. So every case is unique.
Sure. And I know you do have to take it on a case-by-case basis, but you bring up an important point, the comorbid factor of some of these medical conditions that are really serious, Dr. LeBlanc. I mean, we're talking hypertension, we're talking diabetes, some things that are life-threatening in themselves in some cases, right?
Oh, yeah, very much so. And the most significant is it can have you die overnight is obstructive sleep apnea.
Wow.
That Reggie Jackson, the football player, died of that very thing. It causes an arrhythmia of your heart.
Many times people don't think about all of those other factors that may be going on for people who are overweight to a certain level. You just think, well, if you just lose weight, you'll feel better. But it can be really serious.
Very serious. And so anybody that wears one of those CPAP machines or BiPAP machines, that's something they should consider as a cure of it.
Absolutely. Don't forget to send us your questions at that email address at the bottom of your screen, socialmedia@ollrmc.com. We'd love to hear from you anytime as we proceed through this webinar. I want to point out that with each of these procedures, we're talking about a laparoscopic surgery. Now, that's a term that's been around for a while. People have heard it. We may use it even and not really know what we're talking about. Dr. Klein-Peter, describe for us a laparoscopic procedure as opposed to an open procedure, the more traditional procedure.
The traditional approach simply involves making an incision, getting into the abdominal cavity, working directly with the organs with your hands and instruments. Laparoscopy uses smaller incisions on the order of half an inch, sometimes larger depending on the need for larger instrumentation. But it allows you to minimize the incision size, which is incredibly important for these patients to be able to move and walk, even the night of surgery. And
wow.
It's an expectation. So they really do recover much more quickly, and it's much safer in terms of preventing things like pneumonias and blood clots, which can be life-threatening.
Sure. Now, Rachel, when you heard that the options were all laparoscopic and started kind of considering this, was that important to you that you wouldn't have to have a big incision and maybe a whole lot longer recovery period?
Yeah, that was important. I mean, you got to work and get back to life, and
sure.
knowing that you could do that quickly,
Made a big difference, I'm sure.
It did.
I'm sure. We are getting some questions in from our viewers online, the folks who are joining us and participating online. Now, one of the questions that has come into us, and referring back to people who have other conditions besides, just an obesity issue, as we said, diabetes, what have you, can they immediately stop taking medication after surgery? What kind of recovery might need to take place before a patient could safely get off medication? Dr. LeBlanc?
Well, patients that are diabetic, which is the majority, they have to very carefully monitor their sugars. Because in some cases, the patients have to stop while they're still in the hospital.
Wow.
And they only stay in the hospital a night or two. So it's that dramatic in some cases.
Gosh.
But the blood pressure is the other thing. Blood pressure medications, they have to monitor that very carefully just so that it doesn't drop too low.
Right.
It's amazing how quickly some people get off these medications.
That's very good to hear. Very good to hear. What about insurance? Is that just on a case-by-case basis, Dr. Klein-Peter, or will insurance cover this procedure? I say this procedure, will insurance cover bariatric surgery?
There are usually policies that speak of bariatric surgery on a whole as whether or not that's covered or included within that policy, and that's definitely on a case-to-case basis. Many of the providers, though, have begun to cover sleeves. Traditionally, bypass and bands were covered. More and more have begun to cover sleeves, and it makes a huge difference for a patient who sort of knows about the three, has made a decision and wants a sleeve, but can't because of difficulties financially and not being able to be covered by insurance. That is now changing, and that's a nice thing because it gives another option.
Sure it does, absolutely.
But it's an incredibly slow process, though, because there's still a fair number of insurance companies that unfortunately don't.
So I guess the best advice to that person who asked that question is check with your own insurer and talk to your physician about it and see what may be reasonable for you.
Right,
at
we
this
have people
point.
in our office, that's what they do all day long.
Okay, well, that's good to know. That's good to know. You handle all this technical stuff, let them handle that technical stuff. A minute ago, we talked just very briefly about these different types of bariatric procedures, the three. Doctors, let's go back over them again, and maybe if you could give me a patient profile, a hypothetical of a patient who might be best suited for a particular procedure. Dr. LeBlanc, with the gastric bypass, can you talk about a patient who would be a good candidate for this procedure?
Well, the larger the patient, we find that if there's different grades. I mean, Kenny talked about the BMIs around 35 or 40, but we're seeing patients that have BMIs 60, 70, that
Wow.
you're going into the super obese. And those patients that have larger might do better with the bypass rather than the sleeve, particularly the management of the diabetes. And you probably, in those larger patients, might have greater weight loss with the bypass.
Wow. Okay. Adjustable gastric banding, the lap band, good option for whom, Dr. Kleinpeter?
The band is nice for somebody who may need to lose a little less weight, and I say that vaguely because every case is a little different, but historically speaking, on average, we've seen people lose a little less weight with the band, and so if somebody wants to lose 50 pounds or 60 pounds to put them in a healthier range, that's certainly an option. Another feature is with the bypass, it may be very difficult to do that operation if they've had multiple operations in the past. It's a little easier to do a band in that respect if someone's had multiple surgeries because the access is really more confined to the upper abdomen rather than any lower with the bypass.
Okay. All right. Now, the sleeve gastrectomy, as you said, Dr. LeBlanc, that's really popular. You're seeing a lot more people want that. How do you narrow down who it's best for? Or is it pretty much broadly across the board?
It's gotten to where when it first was introduced, it was really limited to the lower weight patients. But nowadays, the results and the success are so good that it's almost virtually comparable to the bypass, which
Wow.
was at one time considered the gold standard.
Wonderful.
So it's really made a dramatic. That's why it's so popular.
That's
because
great.
it does its job.
That's great. I think we have a graphic that shows all three options with risks, with benefits, with some of the bullet points there, bypass, sleeve, and banding. When you look at it all, one thing that stands out to me, doctors, is that with a sleeve, it's irreversible, right? We do want to point that out. So you really do have to make some choices that this is something that you're going to do. Also, the compliance, and Rachel, you're very familiar with the need to stick with a program. It's not over once you have that surgery. When you're talking to patients pre-op and really trying to decide what's best, would you potentially go over a list such as these with the bullet points, each option, and see what really works best? I guess you have to get to know these patients pretty well.
You do, and there's other little tweaks on the considerations, because if somebody's a sweet eater, the bypass, one of the side effects of the bypass, it makes it very difficult to eat sweets.
Wow.
But not so much with the other two.
Now
And
that's
so-
interesting. I wouldn't have thought of that, but that
Yeah.
would be a consideration if you really have a sweet tooth.
Well,
That's
the
something to watch.
bypass segment that we actually create does not like if you put high concentrated sugars into that first part of that small intestine, and you get it's called dumping syndrome. You get sick.
Oh,
You
my
get really
goodness.
sick. It won't kill you, but you feel like you're dying.
Yeah, you wish you hadn't done that, I'm
Yeah,
sure. Okay.
yeah.
Wow, that's something. We do have another question from one of our online participants. How do I know which surgical procedure is right for me? What questions should I ask my doctor? I guess, and what information should I give my doctor? Dr. Kleinpeter?
This picks up from that conversation. I think each of the surgeries has a feature that may make a patient say, wow, I like that, or may say, no, I'm not interested in that at all, or I'm bothered by that. The band, it would be the fact that there's a foreign body at all. Some people just don't like the idea of that. Others like the band because it seems less invasive. There's no division of intestine, right in the rerouting, and so some people like the idea of that. It seems a little less extreme. The sleeve is, like you said, that's one of the key points, the fact that there's a segment that comes out and is gone forever. That may bother people enough to not want to do that. But in terms of what makes a patient a better candidate for one or the other, I think certain features that they may have in their medical history, whether there's reflux, because some of the operations are better for reflux than others, diabetes history, how heavy they are, all those things come into play, previous surgical history. So there is probably a better operation for a patient versus the other two, depending on their specific history.
Dr. LeBlanc, anything that you particularly want to know from a patient as you're discussing options with them? You have a list of standard questions and then you kind of fine tune them to the patient?
Yeah, pretty much. The first question I ask the patient is how much weight do they want to lose?
What's your goal?
Yeah, what's your goal? And that helps you determine which, and then might be a better candidate for which one. Mm-hmm. Again, a sweet eater is a big one for me.
Sure.
The longer the patient has diabetes, it sometimes factors into those sort of things. And then they have to be able to comply. If they get the adjustable band, they have to know that they're going to come back repeatedly, at least once a month for several months. And that's the main considerations. And then you tweak it based on what the patient's goals and expectations are.
You know, one of the things, and this has really been a learning curve, I think, for all of it, well, at least for the two of us, for the ladies on this panel. Gentlemen, you came with the expertise, but we have learned along the way in researching and your own experiences. One of the things I learned that stood out for me is about that hormone, ghrelin. Dr. Klein-Peter, am I saying it right? Tell us about that. When we talked earlier, you were explaining it, and Rachel was saying, yeah, I get it. That kind of came to bear for you in your experience. Tell us about that.
Sure. So in the normal physiology of eating and the gastrointestinal tract, ghrelin is a protein that plays a role in regulation of appetite. So you eat a meal. The farther you get from that meal, the higher the ghrelin levels become to stimulate appetite. You eat a meal, then those ghrelin levels drop off. So in general, the higher your ghrelin level in the bloodstream, the higher your appetite level. That's one way to say that. There's a certain segment of the stomach that produces ghrelin, and that's high up in the fundus. That actually comes out in a sleeve, and so the removal of that portion of the stomach is a very important part of that operation, the sleeve specifically, because those ghrelin levels drop pretty dramatically, and there's studies that have looked at that. The band, that area is not removed, and so that's a bit of a concern. Will that ghrelin level increase, as the patient begins to lose weight? Okay. And can that become a problem? And the bypass does a nice job of excluding that area from the flow of food, and that probably plays an important role with the bypass. So it's very attractive for the sleeve that happens, and can definitely help.
Okay, and you're going, Rachel, tell us about that. I didn't know anything about this hormone. I mean, have you noticed?
Yeah, I can notice a difference. I'm not usually as hungry as I would have considered in the past. My appetite's not quite there. On the other side of that, you have to have self-discipline and know that you don't want to just eat for the sake of eating. It's, you eat when you're hungry, and I do get hungry. Of course, it doesn't take much to fill that now, You got to know when to stop and when not to eat.
Sure.
Just for the sake of habit.
And why you're eating.
Right.
Well, I'm bored, or well,
eating?
I'm nervous,
Right.
or whatever. Exactly. Before we get into more of Rachel's story, I do want to talk about the risks involved here, because as with any surgery, there is risk. I mean, we have to face that and to acknowledge that. Dr. LeBlanc, are there specific risks to the gastric bypass that would not be with the other particular surgeries?
Yeah, the main one to consider is the bypass segment itself. The exclusion of the part of the stomach that is excluded can actually, if the patient, and I have seen this in a few patients that have, particularly women after they've had a hysterectomy, that if they get a blockage, which can happen after any abdominal surgery, the normal case, the patient would come in and you treat them conservatively, possibly with the tube in the nose and that sort of thing, and get over it. But with this, because that stomach is excluded, if you do that, that could put them at risk for perforation of the stomach.
Real serious.
Yeah, so those patients, particularly if they have that situation, which doesn't really hardly ever happen, but if they have it, then you have to take them to surgery sooner than later.
Sure. So they need to pay attention to what's going on with their bodies.
Very much so.
Yeah.
Very much so.
What about risks with the band, Doctor?
The band has very specific risks based on the fact that the foreign body is present and will be there essentially forever. It can move, it can migrate or slip is the term for that. There are situations where that can be corrected by removing all the fluid from the band, letting the body readjust again, and sometimes that will be enough to help, and then readjusting it back to a tight restriction. Alternatively, if that happens again, or if there is a potential that there's trouble, the stomach is becoming ischemic or has lost its blood supply, then an immediate surgery might need to be done to remove that band. Alternatively, one of the major issues is if it's too tight, too restricted, it becomes harder for patients to swallow, even to the point of vomiting, and so it becomes a fine-tuning episode where you have to remove some fluid and play that balance.
Wow. Yeah.
And that's why that takes some time, and that's what Dr. LeBlanc referred to in terms of several months of adjustments to get it to the right place.
Sure, and really staying on top of it, it sounds like. Risks with the sleeve gastrectomy, Dr. LeBlanc?
Well, the main risk with the sleeve, which is also a risk for the bypass or any part of the intestine you actually cut across, even the appendix, is that where we've done that it might not heal properly. We can check to make sure it's not leaking when we're done. We do that every time. But if that doesn't heal, then there's a potential for that leak. It's not that common that it happens, but it's a really it's a hard problem to deal with. You can deal with it, but it's not fun for the patient.
Wow. We're going to talk some more about compliance. We're going to talk some more about your experiences as physicians in performing these surgeries, but we want to get to Rachel's story. But before we do that, we have a couple of more questions from you. We want to acknowledge you, our online participants. Compliance. You mentioned compliance after surgery. What do you mean by that, doctors? Either one of you. I know that probably involves pushing away from the table a little bit. Would you say? Or?
Well, the operations tend to force you to do that. It's interesting that patients literally have forgotten what the feeling of being full is.
Wow.
And these do that. They make you feel full.
You have to kind of relearn what that is, I guess. What that feeling means.
And I recently had a patient in the hospital that after a sleeve, that she was vomiting, and I said, "You're not supposed to vomit." And she says, "But I didn't eat anything." I said, "But you ate too much." She said, "All I had was 2 teaspoons." I said,
wow.
3 teaspoons. And I said, "That was 1 too many."
Wow.
So she didn't believe me, which they usually don't, but I said, "Well, I'm not going to let you eat for the next 12 hours."
Oh, my goodness.
And amazingly, her vomiting stopped.
Well, there you go.
And then she believed me.
What were you going to say, Dr.
I'd make a point, too, for patients who are considering this and for those who've had the surgery. You have to be compliant and sort of think about the choices you make daily forever. This is a point A where you have a surgery. That's not where this ends. That's just the beginning. And so there have certainly been patients who've lost the amount of weight they would liked and then at times gained weight again. So that is possible with any of these surgeries. And so it becomes very important to continue to make those decisions and choices over the course of a lifetime.
Sure. This really is a big change.
Sure.
It's clearly a tool. It's just a tool. And if you don't use that tool properly, you can defeat it.
Sure.
And so that's why we have the patients. They don't get rid of us for a while. We like to keep them
You're in this
back.
together, right?
Yeah.
You're a team. Well, Rachel Wheatley knows an awful lot about the sleeve gastrectomy. That's what she had. That's what she went through back in April of 2009.
2009.
Wow.
Long time ago.
Yeah. Rachel, tell us a little bit about what led you to the point of considering bariatric surgery. You had some other experiences that didn't pan out so well, right?
I did. I had several situations. I was having some health problems as well, and tried various different weight loss approaches, and none of them worked, or they might, and then they quit, and just whatever it is. And I was interested in finding out, what to do. But my main thing is my grandmother one Christmas told me that she would support me any kind of way, whatever I decided, whatever I looked into. And so I checked into a few different ones, and this was one that had the most support system, going into the support, and had the most success. So it was right for me.
That sounds wonderful. I can definitely tell that. You have kind of found a new normal. Does that make sense? Is that a good way of putting it in terms of your self-image as well as lifestyle and eating habits? Is that a good way of describing it?
That is a good way of describing it, yeah.
Okay.
Everything changes and becomes different.
I'm sure it does. I'm sure it does. All right, let's talk about the surgery itself, because people out there may be thinking, gosh, this sounds great, and seeing you on the other side of the surgery, all this is fine and good, but what's it like? I mean, what is it like from the patient standpoint? Can you describe it to us, what you had to do going into the surgery, how it felt?
Prior to the surgery, I did do a liquid diet for a little bit. I think that was to decrease the size of my liver, if I'm correct. That was nasty. I won't lie.
Only way of putting it.
But it was good. I mean, it was needed. It was necessary. So then, going in, you had to make sure that you knew what you were getting into, and you were prepared, even in your mind, knowing that this is, like y'all said, it's a tool. It's not a cure-all. It's not a fix-all. And I still have to work at it today. Got to exercise, got to do what's right. Mm-hmm. And sometimes you don't want to make those choices, but you have to. Mm-hmm. But then having the surgery, I think my worst part was the nausea.
Mm-hmm. Afterwards?
So, yeah, afterwards.
So how long were you in the hospital afterwards?
Overnight, so maybe a day or two. Mm-hmm.
And the overall recovery, about how long after surgery did you start feeling better?
I went back to work definitely within, I was out for a full week, and the second week I went back to work. I did half days. I didn't realize how tired I would be. But within 2-3 weeks, I think it was 2 weeks after, I went walking with the lakes with the New You support group. So
great. Yeah, and the New You support group is the support group here at Our Lady of the Lake. That was one of the questions that came in from one of our online viewers. What will my recovery be like? And doctors, is this pretty typical? It takes about a week to get back to some activity. Does that sound familiar, Dr. Blabaugh?
Yeah. We don't like the patients as long as they're driving, as long as they're on any pain medication.
Sure.
But, when we first started doing this, I said, you got to take a month off, and we got to be careful and all
Real
that sort of
dramatic,
stuff.
yeah,
and then
yeah.
I see the patients a week after surgery, they drove themselves there and said, I'm not going to do that, doc. I got to go back to work.
Wow, yeah.
And so now we just kind of let them do how they feel.
Sure. And I
everybody's
guess
different.
people's lifestyles do dictate what they need to do, right, Dr. Kleinpeter? Can you kind of gauge that on a case-by-case
Sure.
basis?
You know, I think in terms of the recovery, the pain and the incisions is similar to gallbladder surgery for those who've had that and know that recovery. But the biggest change, I think, is sort of learning your eating habits, how quickly to drink, how slow to drink, you know, relearning eating, portion size, plate. You know, you think of a plate that we use as being this big, you've got to think of something this big or smaller. So that process probably goes on to a degree for a long time, if not forever, to remind oneself, wait, I need to cut back a little bit. So I think that's the hardest part. The other one in Louisiana, certainly in the summer, is dehydration.
Wow.
You know, you can't
Didn't think
just
about
take,
that.
you know, a whole thing of water and drink that quickly. It's really important that they keep that with them at all times and really just sip from that
and
through
sort
the
of
day.
sip, yeah.
So that dehydration may play a role in terms of why someone feels so tired for a period of time. It's just hard to keep up.
Right.
And that's the patient that, because we have them, the patients that work out in the yard or something, and not in the yard, but in their job.
Sure,
and
out of doors.
We don't let them go back to work for a bit because they can't take in enough water. And
Sure.
you can really get dehydrated.
You really have to make some concessions for this, don't you? Yep. There's a learning curve, like we said. There really is. Rachel, what about going out to eat? I mean, talking about these portion sizes, we are so used to the big size, the oversized, that you need all this, you need it. It's not enough if you don't have it. It's a mental game, kind of, isn't it?
It is. I found the best way to do a portion sizes was to eat off of the plates of my friends and family.
Just nibble,
like,
kind of?
Quite
Yeah.
frankly, yeah. Or if it was a situation where I was getting my own meal, I would generally always ask for a box at the same time as I ordered. And I said, I would like it first, please, thank you. Because I knew I knew I wouldn't eat it. And I'm still human. You still sit there and look at it and go, well, maybe one more bite, and that one more bite does it in a very bad way.
Yeah.
And so
you learn.
Yeah, you do.
You definitely learn. We have another question about the support that's offered to patients here at the lake. And Rachel, I just kind of want to go back to that again. You had some exposure to the support group before you made the decision to have the surgery, right? You sort of knew it was there.
Yes, I did.
Yeah, and that was a key factor for you. How important is this group even now? Okay, you're 3 years plus post-surgery, but you still think of them as being there for you?
I do. I talk to several of them on a daily basis, you know, whether it's on the phone or whether it's on Facebook or whatever. I need to be in contact more. I always think more contact is better because we need to be there for each other. But I need to be there more for the new ones too, you know, because I know what it's like going through it.
Absolutely. You know, you make a good point. I thought about this afternoon, doctors, that probably you have new patients or patients who are considering this procedure who would benefit from talking to somebody who's been on the other side of it, because they can tell you from having been there. I mean, you know it as a doctor, but you haven't had the surgery yet. So do you find that that's part of what you advise people?
There's a saying that every day is a school day. You know, you never stop practicing and learning. And so we're constantly learning things or questions that arise in support group that you hadn't thought of, that you might say, wow, well, this, and somebody next to her may have had that exact experience and say, well, here's what I did, try this. So the support group is everything. Again, point A, you have surgery. There's so much more to it than that. You know, the support group's a very powerful tool, and these are strong relationships that develop over time. I mean, there are a lot of ideas that get exchanged, experiences and stories, and so it's nice that they have that for each other. I would warn, though, it's sort of and almost makes you kind of sad. I think people feel guilty if they don't do well and don't want to come. That's the exact person who needs to be there. So I would sort of implore the patients, please don't do that. You know, we're here to help.
Don't back away. Jump right back in the middle of it.
A lot of people just kind of forget, or they get off the bandwagon as time goes on.
Sure.
And the support people are quick to fuss at them.
Well, they hold each other accountable, probably. Is that a fair way of saying it?
It is. You know, sometimes it can be intimidating. Like every now and then, you know, things do go wrong, you know, but you got to get back on it and you got to do what's right. You know,
every day's a new day.
Yeah,
right?
every day is a new day.
I tell myself that about a lot of things. Now, here's a question that probably everybody is wondering who has an interest in this. How much weight will I lose, and will it happen quickly? Dr. LeBlanc.
Well, everybody asks that
question. Put you
question.
on the spot with
Everybody
that one.
asks that question, and it's an impossible question to answer, except for the last part. You will lose it quickly.
Okay.
But what I tell patients, you can kind of gauge the first month. I say whatever your weight is, you can predict about 8 to 10% of that weight the first month.
Wow.
And that's with the bypass and the sleeve. It's much less than that with the band. But it takes about a year and a half to lose the weight with those two operations. The band can take 2 to 3 years.
Wow. So you really have to be patient if you opt for that.
Right.
Yeah.
Right.
Yeah.
And but in a year, your body, a year to 18 months, your body just kind of decides that's where you're going to be, and then you just stop. The patients that over long term that do the best, though, are those that actually exercise.
Interesting. All right. Let me ask this question that just came in from one of our online viewers. You talked about eating only 2 tablespoons at a time. How many times do you need to eat in one day, and do you need nutrition supplements? Dr. Kleinpeter.
Very important point.
Sure.
Certainly I'll address the first part first. You talk about eating more frequent meals through the day. There's a sort of a middle ground there. You have to be careful that that's not 10, 15, or 20. If it's 6 or 7 and you're getting enough to sort of stabilize yourself and get the nutrition you need, that's fine. But if you go beyond that, it starts to become counterproductive. So yes, you definitely need to have the mindset of smaller meals somewhat more frequently, because 2 or 3 won't do it. The multivitamins is an incredibly important point. Certainly for the bypass, patients are at the most risk of that because there's been an area that does not see food and is important for absorbing some vitamins and minerals. We now have to supplement sort of over and above what would normally be there to keep up, and that's the bypass specifically. So those patients really have to be aggressive about keeping up with supplements over the course of a lifetime. The sleeve and the band need to do that as their diet adjusts, but because they don't have a bypass segment, they still absorb, as much as you or I in terms of how much multivitamin or mineral is there. They can do better, but they should supplement themselves as well. The bypass is just much more important.
Gotcha. One more question here from one of our online viewers for now. We have several more questions, but are there any steps needed to prepare mentally for this procedure? And that was actually on my list because it's physical, but it's also mental.
Huge deal.
Let me ask you this. Let me put it in these terms also. When you're talking to a patient, how can you tell that that patient is ready mentally? I mean, when we think about this, it's a huge life change, huge lifestyle change. As with any change, we have to be ready to take on the challenges as well as the rewards. How can you tell your patient's ready?
Well, the vast majority of them come in, and we're not the first person they've talked to about this. They've actually got online and they looked at all the different resources and stuff like that. But we actually have everyone evaluated by a psychologist or psychiatrist.
Wow.
Because not very often. We're not really trying to see because everybody's crazy, we're not really looking for that. They will help us evaluate the patients for if they have a good support system at home, if they're ready in their lives to do that.
Sure.
And if they're going to be compliant to the needs that their operation would require. And so that's part of the process. And we also have them meet with the nutritionist too as part of the program. And the nutritionist has input to make sure they understand what they're going to have to do, what foods they're going to be able to eat, and when they're going to be able to eat what foods.
Sure.
So, and if they can understand all of that, then we know that they're ready. But it's a whole group of people that make all those decisions.
Wow. We talked a little bit about the importance of exercise, and we all know that exercise is important, but you mentioned somebody who did better, or the fact that people do better if they add exercise. Should someone begin an exercise program prior to surgery if they say, okay, I made the decision with my doctor, let me go ahead and get on that treadmill, or should they really wait until after the surgery? Dr. Kleinpeter?
I think, there is in situations lead-up time to surgery, which can be 3 months. It can be very quick. It could be a few weeks. But if there is a period of time, it's nice to begin a process like that, and because you want that to continue as much as it can around surgery. There's obviously a time, 2 weeks to 4 weeks, where the patient might not be ready for that. But an example of a patient who would come for surgery would be somebody who has knee trouble, and they're considering a knee replacement. It's very hard for that individual to do effective exercise to lose any sort of weight. So that person, you might sort of say, hey, look, let's do surgery, let's get you to lose weight, and then we'll start talking more about walking, because it doesn't have to be weightlifting. It can be walking, it can be swimming, it can be biking. All those things are, effective. So there are times when a patient would do well to begin the exercise process beforehand if they haven't already. And then there are situations where circumstances dictate that they wait till afterward.
Rachel, how did you approach exercise in looking at your surgery coming up? Before you had the surgery, were you exercising then? Or
I did exercise ahead of time. I knew I wanted to do it. I always tried to exercise in general. I mean, your ankles hurt, your feet hurt, everything hurts.
And you're busy. You work.
Yeah,
you're a
busy too.
businesswoman. Yeah, sure.
But a lot of times before surgery, like before having really decided to do it, you're depressed about things, and so you don't. But then knowing I was going to do it, knowing that things would change, it kind of gave me the extra drive to exercise. And you need to get in a habit and get in a routine, and so.
We all do. This is good advice for everybody, whether you're thinking about the surgery or not. Now, remember, we do want to hear from you. If you have a question for either Dr. LeBlanc, Dr. Klein-Peter, or for Rachel, please email it to us. That address is at the bottom of your screen, social media at OLOLRMC.com. And we do have a few more questions from folks who are watching us online. Is there an age guideline for these surgeries? Dr. LeBlanc?
Well, somewhat. Pretty much for us, the pediatric group of patients, basically someone under 17, 18, we just don't operate on those. We don't do that side individuals. And but there are places around the United States that are.
Okay.
And it was years ago considered an experimental procedure, but if you have a child that's 16, 15 and weighs 300 pounds, they're never going to lose that weight.
Sure.
So there are places that are doing that.
Is there a cap on the age, on the other
Well, on the
spectrum?
other end of it, a lot of it depends on all the factors that we've talked about, the weight of the patient, all the comorbidities, because frankly, if someone gets with a lot of medical problems, then any surgery would become risky.
Sure.
And so there's not, per se, there's not, if you're X amount of age, that not necessarily so that there's a cap.
Yeah. Now, Rachel, we talked about your journey and how you kind of went through several different steps and experimenting with different things, not to your liking, not to your success, to get to the point of saying, okay, the next step is. What is the first step for a lot of people? Dr. Klein-Peter, I guess the better way of asking it is somebody just asked us, if I'm interested in weight loss surgery, what is the first step that I take? Do I call a physician, general practitioner? What do I do first?
Certainly. So in terms of the mechanics of that, sure, talk to your physician. It can be difficult, although objectively speaking, most physicians would check a height and a weight and can tell you a BMI in a very objective fashion. But it can be a difficult conversation at times. If the patient brings that conversation to the forefront, that's a much easier thing to do. So absolutely, if the patient thinks that a physician is a nice place to start, because they can then gauge, okay, is this patient going to do better with a medical sort of guided weight loss treatment therapy there, or is this patient going to be somebody whose surgery could benefit? So that's certainly one way to start. Another one is just soul searching, talking to family. I mean, I think we talked about family and spouses. It makes me very nervous if they don't have a big role in all this. If you can imagine someone trying to quit smoking, for instance, if the spouse continues to smoke while the other doesn't, it's going to be a very difficult thing. So it's really nice when the family's on board, understands, and is a part of all of the visits, pre and even post potentially. So, but yes, a physician is a great place to start. But even having those thoughts amongst yourself, that's probably the trigger to sort of say, hey, listen, let me look at all the options. And surgery's one. It's not for everybody, but it's an option.
Something to look into, sure. All right, here's a question from somebody who likes to party a little bit. After surgery, can you still drink alcohol and have a beer? It's a good question.
Yeah, it is a very good question. This is part of what the decision-making process between choosing which of the operations.
Okay.
Because
kind of like with the sweets, you have to take this into consideration?
If you have the bypass, the same thing with the sweet situation. If you have a bypass, very, very likely, one glass of wine would bring your blood alcohol level above the legal limit.
Oh my goodness! You really have to pay attention to that. Yes, Rachel's saying yes. You're aware of that, huh? Yeah.
Yeah. Even with the sleeve, you have to be real careful. Can you do it? Yeah, but you have to be real careful.
Wow. Now, here's something I hadn't even thought about. Is plastic surgery necessary after weight loss surgery? I guess maybe a tummy tuck or something like that? Or, I mean...
Multiple sites that they're referring to. One would be under the arms. Some people want to remove excess tissue there. The abdomen, tummy tuck. The thighs. Those are the major places you hear about people getting remodeling done afterward. Is it always necessary? No. I think you can sort of have a general recommendation or sort of finding that the younger the patient, the more likely they are to come back and not necessarily want that. The older the patient, the body changes over time. It's more likely that they would have redundant skin, and that also largely depends on how heavy they were to begin with. So the lighter the patient, the less likely they are to probably want or need plastic surgery afterward.
How long should a patient wait after bariatric surgery to consider some type of plastic surgery? I mean, is there a threshold? Is there you need to lose the maximum amount of weight and maintain it? Do you have any recommendations?
Yeah, you do want to lose the maximum amount of weight. But the question is when have you done that?
When, yeah.
So the rule of thumb is a year to year and a half, and that's why we have the patients come back so we can weigh them and we can keep a close eye on that. But a general good guideline is if you've gone a 3-month period where you've lost no significant amount of weight, then that's probably after that period of time you could consider it.
Okay.
But most patients don't have plastic surgery.
Oh, they don't?
Most do not.
Wow, wow. We talked a little bit about, we talked about the protein, ghrelin, we talked about the appetite. This person wants to know, how do I control my appetite after surgery? Is it just a process of getting used to the new you, Rachel?
There is, there is a process of that. I make decisions every day, decisions to not drink carbonated drinks. I don't drink Cokes. I make decisions to not do fast food. You know, I'm not going to say I haven't ever had. I have, you know, but it doesn't feel the same. It doesn't taste the same, and it certainly doesn't sit the same. You know, fried food, fast food, all that. It's a conscious decision.
Someone else wants to know what you eat today. Not today, but what do you eat in general post-surgery?
I still always try and get protein first. That's if I don't get protein, I can always tell because my hair starts kind of coming out a little bit. And I eat protein and it's perfectly fine, not an issue. But even to this day, I have some issues with that. But I like to do eggs in the morning. I usually do eggs. Maybe one egg is usually way more than enough, you know, for me. And maybe a half a slice of bread or something, or some fruit. Either way, fruit's always better.
Sure.
Sometimes I'll do salads. Sometimes I do vegetables. Sometimes I'll do a sandwich at lunch. You know.
Can you put butter on a roll or butter on a baked potato? I mean, is butter taboo? You mentioned that you don't eat fried foods, but
I don't eat. I do not like to eat fried foods because it sits heavy. I do butter, but I usually go light on a lot of that kind of stuff.
And what about sweets for you? Are you a lady with a sweet tooth? So you're able to manage that because of the sleeve?
I don't have problems like some people have with the bypass. Now, you have to control them. You can't, you have to have self-control with anything, you know. And whereas maybe before I would have sat and ate a whole carton of something, you know, two teaspoons, 2 tablespoons, this is good. I don't need anything else. You just wanted just to taste.
Wow.
That's all you need. And you need to make sure that you close it off.
Yeah, and put it away and don't look at it anymore,
exactly.
Right? Doctors, is this field evolving even as we're talking about it right now? I mean, the sleeve gastrectomy is the newest of the 3, but are there new things on the horizon as well that we could talk about a little bit, or is that a big question mark out there?
No, there's hardly any branch of medicine that, and surgery particularly, that's not evolving. There's always some improvements, and down the pike there's even some technologies that you can do some of this all through the mouth without getting cut at all.
Wow.
That's all of that's in the experimental phase, and it's a bit away from that. So that's probably in the future. That's going to be something that'll be even better than you talk about minimally invasive. It won't be invasive at all.
That's pretty exciting.
Yeah.
And ongoing education for you as physicians, right? In terms of learning what's going on and that
Absolutely.
kind of thing?
The technology is certainly changing every day. One of the other things, though, that's talked about is what is the right threshold in terms of weight. There are other areas in the world that they are dropping that threshold to lower and lower, that patients can benefit at a BMI of 25, 30 if they're diabetic. So that may be in flux as well. The National Institutes of Health met in 1991 and made the broad criteria that we look at now, but that may well change at some point in the future. Wow. And so a changing threshold is another thing that may evolve.
Yeah, some of that technology that I just mentioned through the mouth, that we actually can do revisional procedures today.
My goodness. So in other words, go back if there's a little complication or something, you can go back.
No, not a complication, just if there's weight gain, particularly the bypass, you can go back and do that.
That's exciting.
Yeah, we're doing those.
You may have touched on this and I just missed it, but who does better generally, men or women, in keeping that weight off? Dr. LeBlanc, in your experience?
They're about the same, I think.
About the same?
Yeah, I think they're about the same. 80% of the patients that have this surgery across the United States are women, though. Men don't seem to care so much about what they look
They
like.
don't.
Yeah, but I'd say it's about the same, really.
Among your patient list, Dr. Kleinpeter, is that pretty much the way it
I'm
is?
trying to think of any specific examples, but I've seen patients regain weight as females, also as males. I haven't seen a striking difference.
Yeah.
Although he's right, there's many more females than males that are doing surgery at this point.
Wow.
But I think that beyond that, a patient, the cosmetics of it is one thing, and I sort of think of the weight loss as a nice side effect. But largely, patients are trying to make themselves healthier, and who's driven to do that? I think I've certainly seen a few more males that I did earlier on, and I think that's probably going to change.
Very interesting stuff. I have one more question for you, Rachel. And talking about what you're eating these days, did you have to change what your list of favorite foods is as you move from pre-surgery to post-surgery? I mean, did you have to give up something that you just love so very much?
It wasn't so much that I had to give up stuff that I loved. I noticed that my taste changed. I'd
Really?
never considered smoothies or soups a viable option. Like,
In the past,
no,
you mean?
yeah, like
Yeah.
why would I eat that? That's not food.
Right, right.
But now I prefer it. I love it.
Very interesting.
Yeah.
So you're happy. I mean, you're a
Oh, yeah,
satisfied
very,
customer
very happy.
all the way around.
Yeah, usually
That's great.
if I go out to eat, just give me a bowl of soup. Just want a cup, little cup. I don't need a big bowl, little cup.
So you're an economic date. I won't say a cheap date, but
I have been told that.
interesting,
But it's an interesting
interesting.
comment she makes, though, about
Yeah.
the taste buds. We've
Yeah, I
seen
would.
that.
That's amazing.
The taste
Because the taste
change.
buds are here. The stomach's here.
Yeah, in fact, there's even people doing research to see how the hormones are all connected, the gut hormones with the
Sure,
taste buds, and
sure.
that's quite an amazing thing, because we've had patients in the past in their pre-op phase, they'll go buy all these protein drinks, and I tell them now, don't
Don't
that.
do that.
You might buy a
don't like
couple, and you love it today,
You might not
but in
like
a
it
month you're
tomorrow.
going to hate
Very
it.
true.
That is so interesting.
Yeah.
Wow, wow. Well, we want to point out one thing that distinguishes Our Lady of the Lake and the bariatric department there, and that is the fact that it is a bariatric surgery center of excellence. That's quite a designation. Dr. Kleinpeter, what does that designation entail? What does that mean?
Broadly, you're talking about a designation that speaks to the volume, quality of care that's given in a specific center for bariatric surgery specifically. They'll look at the volume of cases done by each of the surgeons. They'll look at the volume of cases done as the hospital on the whole. They will look from top to bottom at operating rooms, radiology suites, bathrooms. There are certain,
Wow.
all these in sort of areas in the hospital have criteria that they look at to make sure that we can best take care of a patient who's obese and has certain needs revolving around that. And so it's a huge undertaking. It's a great honor, and it's wonderful that's a part of our program.
It really is. Well, Dr. LeBlanc, you were just sharing with me that you have recently lectured internationally, and I know that it's a point of pride for us here at Our Lady of the Lake that it is a center of excellence.
Oh, it is. It is. We've been doing these in the Baton Rouge area. The Lake's been doing these operations longer than anybody.
That's wonderful.
Yeah.
Well, we thank you so much for all of this. It's been a great discussion. We want to thank you all for joining us via the internet and for submitting your questions to us throughout this webinar. We appreciate that. We appreciate you signing up for this. We think it's important information. We especially want to thank our experts, Dr. Carl LeBlanc and Dr. Kenneth Kleinpeter, for being with us, bariatric surgeons here at Our Lady of the Lake Regional Medical Center. We couldn't have done it without you. Obviously, your expertise, your time is greatly appreciated. They helped us on the front end before we even got to this point to get ready for this. So thank you. And thank you to you, Rachel Wheatley. Continued good success to you, and congratulations on how well you've done. I know you've helped a lot of people. You're an example for folks. Keep doing what you're doing. It's great.
Thank you.
Thank you so much. We want to remind you that we will have clips of this webcast up on our website in a couple of days, so that if you know somebody who missed it tonight and maybe wants to get a chance to get this information, they can certainly do that. Just visit ololweightloss.com in the coming days. That's ololweightloss.com, and you can see some excerpts from tonight's discussion. For all of us here at Our Lady of the Lake Regional Medical Center in Baton Rouge, Louisiana, I'm Margaret Lawhon. Good night.